some indications of people you can talk to, it's also important. So let's move on to the next presentation.
Passiamo alla relazione della dottoressa Murgioni. Buongiorno.
We're going to hear from Dr. Murgioni, logopedist expert in disorders of swallowing and feeding, and she'll talk, in fact, about feeding and swallowing disorders in rare diseases. Thank you.
Volevo prima di tutto ringraziare gli organizzatori per
Thank you very much. First of all, I'd like to thank the organizers for having me here today. I also speak on behalf of the group for which I am the spokeswoman, so to say, today. Well, and thanking for giving us the opportunity to take part in this event, which is a very peculiar one. So some of you already know us as a group. Other people maybe not. So I'd like, first of all, to give during my speech to explain who we are and what we deal with. Well, within the framework of the Bambin Gesù Hospital, there is a ward service, which is for dysphagia. And within this service department, we have a multi-professional team, so different professionals. We are a group of speech therapists we specialized in swallowing. We have doctors and pediatric neuro neuropediatricians, sorry. We deal with swallowing disorders and speech disorders. We carry out assessments in all the facilities of Bambin Gesù and rehabilitation treatments in Palidoro, Santa Marinella, and Cure Palliative. So assessments and consultations in Palidoro, Santa Marinella, etc. So for inpatients and outpatients as well. Well, who uses our dysphagia services? We have families of children who have trouble feeding by mouth with foodstuffs of any consistency. When I talk about trouble feeding, I talk about children that cough while they're eating, or they can't swallow their foodstuffs, etc. And children who are not able to chew, they refuse solid foods and to swallow in full foods. There are children who cough every time they drink water or drink very little due to their physical challenges and issues. Children who have never eaten through their mouth and who have always used nasogastric tubes or gastrotomy tubes. Children who grow insufficiently due to their swallowing difficulties and troubles. Or children who eat less than they should in terms of calorie needs. So children have a movement disorder that is really energy consuming. So they consume a lot of energy, so they don't eat enough in order to address their needs, and they waste energy. Or children who have trouble managing their saliva, so sialorrhea. Children who have vomit reflex, or who vomit during meals, children who suffocate with food, or they have the feeling of suffocating, or children who have habitual respiratory infections, such as pneumonia, so pulmonary infections. Well, GNAO1 is a very rare disease. So also in terms of literature, I have looked for some information in order to understand what the prevalence is in terms of swallowing, so in this type of disease. And I found this paper from 2021. We are talking about 23% of children with swallowing troubles and disorders in GNAO1. From the rehabilitation point of view, so the ability to eat, to swallow in terms of disorders, etc., there is a long way to go. And frankly, I hope that our group in the future can also make a contribution from this point of view. So also from the point of view of the rehabilitation and the treatments that we usually deliver, there is almost nothing in scientific literature. And we try to address GNAO1 children as we do with epileptic children, dystonic children, etc. So dystonia, epilepsy, etc. So they are taken care of in our department. So not all of them have come to our department with this GNAO1 diagnosis. Maybe this is something that is found out later. Then I carried out a research within Bambin Gesù Hospital about the experience of GNAO1 from 2018 to 2023. There were 6 cases of children at Bambin Gesù, 4 male and 2 female patients. The most important early symptoms in the first few months of life that were detected in the children, as we talked about during these 2 days, were epilepsy, hypotonia, and hypertonia or rigidity in the first few months of life. And among the symptoms with the late onset after 12 months of life, we can find a dystonia, we can find a psychomotor delay, developmental delay, neurodevelopmental delay, epilepsy, and feed and swallowing disorders. And more specifically, within Bambino Gesù, out of 6 cases, we had 5 cases affected by feed and swallowing disorders. In order to be even more precise, we had 2 serious cases of dysphagia and 3 delay in terms of abilities in general. Then I also talked about these disorders, so feeding and the swallowing disorders. So I explored that, and we within Bambin Gesù Hospital there was a good network that functioned, that worked very well, and they were put in the right place, so to say. 5 of them were assessed by us. The average age is within 4 years, and just in one case after 13 years of age. And the only non-assessment case is because the child did not have any swallowing disorder. And all the cases were treated in our department. In 2 cases, we carried out non-food training because patients had severe dysphagia. And in other cases, there was an alternative feeding, so an alimentary, food-related treatment. Well, now I'd like to talk about something else. For us as rehabilitators, this is an important guideline. So the rehabilitation treatment must be tailored, must be customized. So we always start from an assessment, an initial assessment. After the assessment, we can identify the rehabilitation treatment goals, and then based on these goals, we can define the rehabilitation training. This is a dynamic process. This is not a static process. Since over the lifespan of the child, needs a change in terms of environment, in terms of clinical picture. So it is important to carry out and to perform periodic controls, reassessments in order to reschedule everything and to redefine new goals and in order to give personalized and customized and tailored rehabilitation treatment. In terms of rehabilitation treatment goals, oral abilities, these can be summed up in 4 macro areas. We have a prerequisites for the meal, then we have the oral sensory area, we have the oral motor area, and the meal behavior. When we talk about prerequisites for the meal, I am referring to what was said by the colleagues who gave the first speech. So we are talking about the development of correct feeding postures. Since the right alignment, head, trunk, and the pelvis is crucial in order to allow children to eat in a safe position and so that he can focus on the motor elementary function. In those cases, if we don't have problems with the tone, with the movement, etc., the use of a specific posture system is the basis, is an important prerequisite. So we have to identify the most suitable posture system, and this is done by physiatricians and the physiotherapists as well, who take care of the child. We, as speech therapists, during the rehabilitation treatment, have the goal of making sure that the child gets used to this feeding posture. So sometimes the child wants to be hugged or want to be in the arms of their parents, so you have to put him seated, and he needs to get used to eating in this right position. As far as the oral sensory area is concerned, I am making reference here to the adjustment and of sensory responses to food stimuli in the oral cavity and the perioral area. For many children, this is something annoying when you touch or when they touch, for example, food, when they have to put the food into their mouth. So there is a desensitization process that should be carried out using those foodstuffs. As far as the oral motor area is concerned, we have different goals. First of all, we have the development of oral motor skills. We have also a chewing training, food, non-food. We have strengthening of the orofacial and tongue muscles. Kind of fluid intake training and work on the coordination between chewing, swallowing, and breathing functions. As regards meal behavior, meal education, we have different goals, the development of suitable food practices, the meal communication routine, and I'm getting back to what the second colleague has said during augmentative and alternative communication, AAC. It is very important for these children going through this alternative communication pathway to bring us the tools that they use on this pathway, since we can involve them actively in their choices. So they can say, I don't want this, or I don't like that, etc. And then also the caregiver training at meal and all the stakeholders and the actors taking care of children, such as toddlers, for example, and school teachers, all the people must be able to understand how to involve all children. We believe in this family-centered treatment system. Our rehabilitation treatment foresee the presence of the parents, and they also learn the rehabilitation strategies, since when they go back home, they have tools that can use in order to help children in their daily life. Here you can find two different situations with which I was often confronted, or I had to face. Well, sometimes, the parents have to put like specific systems, for example, for children. And we are talking about very difficult situations, for example, and yeah, we are talking about something that the child needs as a support. So he needs a percutaneous endoscopic gastrostomy, for example, for the safety and health of the child. But I think it is important to say something that is taken for granted. That children with percutaneous endoscopic gastrostomy can also eat using their mouth unless there is dysphagia. But there should be, we should do rehabilitation work on their mouth, because the mouth is not abandoned, is not given up, so to say. And yeah, percutaneous endoscopic gastrostomy is used also to reach the water or the calorie need for the day, because children cannot use it alone or cannot reach it alone. It can be used in some specific moments of the day when the child falls asleep or when he is sleepy. So this percutaneous endoscopic gastrostomy can be used in order not to skip a meal. It can be used also only for liquids in case of dysphagia. For liquid, it can be used to administer important drugs without risk of dosage losses. And it can be also used as a temporary system. If no longer necessary, it can be removed after medical consultation and multi-professional evaluation. So this is for the gastrostomy tube, the percutaneous endoscopic gastrostomy. The using aquagel or thickeners or thickening powder for liquids is essential in case of oropharyngeal dysphagia for liquids. Sometimes children need thickeners and they need to take enough liquids as thickeners. And it is also possible to modulate the density level from the rehabilitation point of view. This is very important. And you can also thicken any kind of liquid. You can use a thickening power. Well, this is an experience I wanted to share with you. This is a mother who was very nice to me, and very spontaneously she talked about the use of thickeners, of thickening powder, that had a very positive impact on her quality of life and her child's quality of life. Well, he started using or taking these thickened liquids, and the child can also reach the daily calorie need. There are no infections of the urinary tract. And she said, I can also let him taste something like fruit extracts or smoothie foods, etc. And before it was not possible because he used to cough, and there is not this continuous cough every time he drinks. And he has completely changed his attitude, and he likes drinking and eating as well. So just to conclude, what I wanted, the take-home message. So these are a couple of advice, and please talk to a speech therapist and a swallowing therapist if your child have trouble feeding by mouth, if he does not chew, he refuses solid foods and swallow whole foods, if he cough every time he or she drinks water or drink very little due to physical challenges, if your child has never eaten through their mouth and who feed through nasogastric tube, gastrostomy tube, etc., if he or she grows insufficiently due to his or her swallowing difficulties, if they have trouble managing saliva, sialorrhea, if they have vomit reflex or who vomit during meals, if they suffocate with food, this is the case, often the case with solid foods, and if they have habitual or usual respiratory infections like pulmonary infections, so pneumonia, etc. Please do not use rehabilitation strategies seen in another child with the same disease as your child before SLP assessment of oral abilities is carried out. So what applies to a child that does not necessarily apply to another other children. And please do periodic checkups, especially when there is a change in terms of drugs, epileptic drugs, for example, epilepsy drugs, or there are new symptoms that appear. Thank you. Thank you so much.
Grazie molte.
Thank you. Thank you so much. Was very, very nice, very practical. We still have some, well, some time for questions, if you have any. Well,
Grazie, abbiamo una domanda.
thank you. We do have a question from a father who got in touch with us by chat. Well, pros and cons in giving food that is mixed by families through percutaneous endoscopic gastrostomy. What are the pros and cons? Well, the use of a natural diet for your child is a choice. I agree on that, on this choice, since very often we deal with children that start well eating by mouth and then they complete it in another way. So from the organizational point of view, it is much easier also for the parents. So if we talk with nutritionists, for example, dietitians, well, this is not the procedure because they suggest or they recommend already made milk formulas, etc. Because they are well balanced, but they are not always tolerated by children. Sometimes children have they start vomiting when they well drink this ready-made milk, because this is like liquid. Well, while smoothie or a mixed food or meal can be also more compact compared to ready-made milk formula. So we do, well, the rehabilitation therapies. As a rehabilitation therapist, I prefer natural food, but anyway, well, this can vary also.
Volevo chiederle da
I
un...
wanted to ask something about the posture. What can we do? Because sometimes it's really difficult for us as well as therapists, because children move a lot, they are tilted, then this is not good. If they are too straight, this is not good for their head. So are there any postural systems that are a little bit more structured that can be used? Do you use them, or during meals, is there a specific maybe system that is really good structured? And what and how can we use these systems in order to stabilize children so that this is not a constraint for the child, or not a, well, the postural system must be used based on the instructions. For example, you can use something like a specific facility or device like a bib, etc. And the child seems to be a little bit annoyed at the beginning, but this is the only way to keep the child in a straight way. So, and then he can be tilted as well. And it can be very, very useful because you can act, and the child can also better control his or her head if it is a little bit tilted. For example, if the posture varies a little bit, then he is facilitated because the head is much straighter, and also during the meal, so he can start in a specific way, then he can tilt the head a little bit. So there is no fixed, no golden rule, but this is the common rule. And then there are some postural systems that we have seen over years. I don't want to get into details about that. I don't want to talk about these different systems, but if you have like a dystonia, there is a specific posture system that can also counteract the dystonic movement also during meal. So we have seen that they also have a more positive impact, and they are much better respondent. So children can also have a more enjoyable meal. So we still have time for the last question.
Salve, volevo sapere se un...
Yeah, good morning. Well, I'd like to know something about the osteopathic treatment in order to improve chewing, for example. And are there any exercises for the tongue? Because I saw that many children have the tongue very, very in the front part, so to say. So in order to improve also posture, etc., I'd like to know if you have any recommendations. Well, I start with osteopathy. Well, osteopathy is a practice that I really like and appreciate, above all when there are this kind of stiffness in terms of the structures that involve the oral tract. So if we want, can we say that osteopathy can improve chewing? Is it possible to say that? No, I don't think so. As a team, we are firmly convinced that we can work on a specific function, and in order to do that, we need a very specific treatment. So if I have to teach children or a child to chew foods, I have to focus on that specific function. I have to use food. I have to do it through rehabilitation to improve and increase the safety. But I use food. So if you work with non-food, this does not help the development of that specific function, right? And it can help, it can be very, very useful as well. But if children have to understand how to chew, then they have to work on that. We need to be very focused and targeted. I don't remember the second part of your questions, so sorry. Yeah, exercises. Well, these chewing exercises are the most complete and the comprehensive exercises so children can strengthen their muscles and they can also, as a result, develop more control. But we need to bear in mind that the neurological aspect of the disease for the muscle tone and movement plays a key role, plays unfortunately a crucial role. When we have hypotonia, for example, in a child, sometimes the child cannot close their mouth, and since they can't well control their mandibular or their lower jaw, they have difficulties, they have troubles from this point of view. So there are no specific exercises apart from chewing work and exercise. So we need to focus on that. But please refer to a specialist and try to get a rehabilitation treatment that is really customized on that child, so tailor-made. So thank you so much.